Dr. Punit?
Yes.
Hello? Yeah,
Yes.
I think we start. Many participants have joined. I
Okay.
request everybody to mute yourself. So today's topic is approach to osteoporosis. And our speaker is Dr. Punit Mashru, who's a consultant rheumatologist at Jaslok Hospital and HN Reliance Hospital. He has special interest in osteoporosis and has many publications in international journals and presentations also. So let's go on to Dr. Punit.
Thank you, Dr. Nina, for the kind introduction. So we'll start with the topic. So I'll give a brief introduction. I'll give a brief introduction about osteoporosis, and then I'll show you some cases to get a basic approach on osteoporosis. Yes. Osteoporosis is a systemic skeletal disease characterized by low bone mass, deterioration of bone tissue, increase in bone fragility, and which causes increased susceptibility to fractures. It is very common. 1 in 3 women and 1 in 5 men above 50 will experience an osteoporotic fracture. And some of these fractures are devastating. So the hip fracture mortality in 1 year is around 20%. It is much more common than other conditions like heart attacks, stroke, breast cancers. Okay. So this is the WHO classification for osteoporosis. So based on your DEXA scan, they use a T-score of minus 2.5 or below. Or if anybody has had a fragility fracture meaning a fracture with minimal injury, minimal trauma, a fracture from a standing height is called a osteoporotic fracture or a fragility fracture. The etiology, so can be primary osteoporosis, where in postmenopausal women and elderly individuals, or can be secondary causes, which can be because of some genetic abnormalities, hypogonadal states, hormonal endocrine issues like hyperthyroidism, hyperparathyroidism, diabetes, GIT abnormalities like inflammatory bowel diseases, malabsorption syndrome, celiac disorders, and some blood disorders like hemophilia, leukemia, myelomas, and obviously rheumatological conditions like rheumatoid arthritis and drug-induced osteoporosis. Most commonly is the steroid-induced, glucocorticoid-induced osteoporosis. Okay, so we diagnose osteoporosis, as I told you, based on the DEXA scan. So we have a central DEXA. We also have something known as QCT. Based on these scores, if they're minus 2.5 or less, we can diagnose somebody as having osteoporosis. But there are some other devices also that may be used as a surrogate, like the ultrasound or the peripheral DEXAs, but they may not be that reliable. Okay, so we'll start with some cases. We'll start with a very typical case: a 66-year-old female, postmenopausal since 10 years, and she has history of two falls in 1 year, no history of fragility fracture, a T-score of minus 2.6 and hip score of minus 2.1. So she has osteoporosis. So what do we treat this patient with? So any patient of osteoporosis, this is the universal recommendation for all of them. Adequate calcium intake of at least 200 milligrams per day, adequate vitamin D of 800 to 1000 international units per day, regular weight-bearing exercises, balancing exercises, fall prevention measures, avoiding tobacco, alcohol, and excessive caffeine, and identification and treatment of risk factors. So the thing is with calcium supplements is that now there is data coming in that calcium supplement by itself may not reduce the risk of fractures. So I think just encouraging good amount of calcium in the diet is should be enough. Fall prevention is extremely important because whatever treatment we give, in the end, the goal of treatment for osteoporosis is a fracture prevention. So these patients, fall prevention is extremely important, which includes, things at home. Maximum falls happen in bathroom. So installing grab bars, using lighting at night time, doing regular weight bearing exercises, because as we age, the muscle mass starts going down. It's called sarcopenia. So weight-bearing exercises, appropriate footwear, going through a drug list, seeing that if any drug can potentially cause excess of sleepiness, drowsiness, and increase risk of falls, and to assess the vision and look for cataract in the elderly people. Now, coming to the treatment options, we have bisphosphonates, we have ranked ligand inhibitors, we have hormone therapy, then we have SERMs, which is not really much used, and we have parathyroid hormone receptor agonist, teriparatide, available in India. So every agent will work a little differently. So most of them are anti-resorptive agents, and the only anabolic agent available today in India is teriparatide. Every agent works differently in the sense that it works at different sites. So most will work both at the vertebra and the hip, except for abandonate, which will work only at the spine, and as well as teriparatide, which works more at the spine. But there is also data that it also increases the BMD and reduces the risk of fractures at the hip. Though the landmark trial did not show that, but now there is data coming in that shows teriparatide also works at the hip. So this is so we have anabolic agents, anti-resorptive agents, and there is a newer medicine, newer injection called romosozumab, which is going to be available in India shortly, which has a dual action, anabolic and anti-resorptive effect. So in this patient, I gave a IV zoledronic acid. So the recommended dose is 5 milligrams. You give it slow over at least 15 minutes and give it once a year. The adherence to why I chose an IV injection, because the adherence to treatment oral agents is not that great. So we give IV. There is also data coming in that if we use IV zoledronate, you know, uh, more time duration. So we can also give it once in 18 months. Even that will work very well, and we may not need to give once a year. The common side effects of bisphosphonates for the oral agent, the GI intolerance is very common. So if anybody already has a baseline reflux, is on a lot of PPIs, we should avoid using the oral bisphosphonates. Hypocalcemia. So to avoid that, we do a baseline calcium, correct the vitamin D, and after starting the treatment, we must repeat a serum calcium after 4 weeks to see whether there's no hypocalcemia. Then renal dysfunction, we should give IV zoledronate at least over 15 minutes. If we give it faster, then that may cause a AKI. We should avoid it if the eGFR is less than 35 ml per minute. The most common side effect of an IV bisphosphonate is flu-like symptoms. They have myalgia, arthralgias, fever. It occurs in 50% of patients and can last for a few days to up to a week. The way we prevent this from happening is we typically give paracetamol uh, at the time of the injection for a couple of days. But even then, some of the patients still develop these flu-like symptoms. So there's data coming in where it has been shown that giving tablet dexamethasone 4 milligrams for 3 days will also significantly reduce this side effect. This particular side effect, if the patient had it once, the chance of happening it again will reduce over a period of time. So with first dose, there's a higher risk of these flu-like symptoms, but as we give it the next dose, the chance will be little lesser. And then there is osteonecrosis of jaws and atypical fractures side effect, which I will discuss a little later. Coming to the next case, this is a 46-year-old lady who was told that she is going to a fracture because her hip T score showed a T score of minus 2.6, and so, but this patient is premenopausal. So, in this patient, we look at the Z scores and not the T scores. So you can see the Z scores is -2, and if the Z scores is less than -2, only then it is low bone density and not osteoporosis. So we should use Z scores in premenopausal women and men less than 50, which is very, very important. So this patient has normal bone density and just needed counseling that the bones are normal, and we sent her back. Third, coming to the next case, 42-year-old female, postmenopausal. She had hysterectomy at 40 years. She had osteoporosis. Spine is minus 2.7, hip is minus 1.4. And these are all the options that we have for treatment. But it is important to remember that there is a finite duration when we can use all our treatment. So we should use our agents when the fracture risk is high. And in this particular patient who had an early premature menopause, hormone therapy is a good option unless there is a specific contraindication. They used to be concerned regarding hormone therapy with regards to cancer risk, breast cancer risk. But it has been shown that only in combined hormone therapy that this has increased, shows increased risk. The estrogen only therapy does not increase the risk of breast cancers. So if a patient has premature menopause, I think sending to the gynecologist and speaking with them, discussing with them that is it possible to give these patients hormone therapy, it will be important rather than putting these patients on bone-specific osteoporosis treatment. It's a 26-year-old female, postpartum body pains, and she went for a health checkup, and it showed a very low bone density. T scores of minus 3.6, D scores of minus 3.2. Very so at the spine and hip both. But if you look at it, the vitamin D is very low, calciums are low, pH is high, alkaline phosphatase is high, phosphorus is on the low side of normal. So this is osteomalacia and not osteoporosis. And if you see that just correcting the vitamin D and correcting the osteomalacia, the bone density has significantly increased at the spine of at around almost 60%, and the hip of against almost 60%. This is a 50-year-old female. Next case, 50-year-old female, progressive difficulty in sitting, getting up from the supine position, difficulty in walking since over a year. She had a waddling gait, painful movements in both the thighs. And you can see that this patient has a fracture here, and this is a pseudo fracture. So we were expecting a normal, we were expecting a very low vitamin D, but the vitamin D is absolutely normal. Calciums are low normal. Alkaline phosphatase is very high. All the other workup is normal. But there is one test which is missing, which will give us a diagnosis, and which was not done for many, many years, was of phosphorus. A phosphorus is 1.7, very, very low, very low. And we evaluated this patient, got a FGF23 done, look for renal tubular acidosis. So the FGF23 came very high, and we did some. We wanted to look for oncogenic osteomalacia. We did a DOTAT PET scan, which showed soft tissue nodular lesions, two in number in the upper lateral part of the thigh. And she underwent a excisional surgery, and there was a dramatic improvement. Her phosphorus just normalized, her pains subsided over a few weeks, and she was doing extremely well, and the fractures healed. So oncogenic osteomalacia, they are acquired paraneoplastic syndrome caused by small, slow-growing mesenchymal tumors secreting FGF23. They are benign. They're frequently found in the areas of the sinuses, some in the bone or skin. They have typical symptoms of osteomalacia, and the diagnosis is missed for years. These tumors are very hard to find, so we need to use those special tests like DOTAT PET scan. And the landmark is the hallmark is the very low phosphorus. So anybody having a phosphorus of less than 2, we must go in detail and evaluate in detail. So we must look at for renal tubular acidosis. We must look for these oncogenic osteomalacia. Look for are they on any medicines like in HIV, tenofovir can cause osteomalacia. These are important things that we must look at. Coming to the next case, a 32-year-old female, low back pain, acute onset on lifting her shopping bags, and X-ray was done, which showed a L1 vertebral compression fracture. bone density was done, and it showed very low bone density, T-scores of minus 4.4. But she's young, so we should look at the Z scores. So it showed minus 4.2, and she was advised the vertebroplasty surgery and injection teriparatide by the orthopedic, and but we evaluated, and the calciums were very high, PTH was very high, vitamin D low. So she had a left parathyroid adenoma, which we confirmed the technician system AB scan. And she underwent a surgery, and just treating that, her bone density normalized at the spine and the hip. So a dramatic 70% improvement at the spine and over 60% improvement at the hip. So the take-home message is that a DEXA scan cannot differentiate between osteoporosis and osteomalacia. And we must always look up for secondary causes, especially in younger individuals or when the BMD is lower than expected. So, what are the evaluation that we should be doing? We should do a complete blood count, ESRs, biochemistry, calcium phosphate, LFT, creat, vitamin D, thyroids, PTH. If we're suspecting, so we should do 24 hours urine calcium, especially if somebody has recurrent kidney stones, or we're suspecting some malabsorption syndromes. That will be helpful to diagnose. TTG for celiac disease, serum protein electrophoresis, especially in the elderly individuals, especially if they have a spine fracture, or they have anemia, or they have a little bit of hypercalcemia, a little bit of elevated creatinine. This is when you should do a protein electrophoresis, or ESR is high. Another thing is serum cortisol. Okay, coming to the next case. So 71-year-old female has a DEXA T-score spine of minus 2.1 and hip of minus 2. Her mother had history of hip fracture. So should we treat this patient? Should we just rely on a score of minus 2.5 and treat only those individuals? Or we should treat patients who have even osteopenia, or possibly even somebody who has a normal bone density? So what is important to know is that although the risk of fracture is highest in the osteoporotic range, uh, but more number of fractures occur in the osteopenic or normal BMD range. So there is something beyond the BMD which increases risk of fractures. So that is why many experts came together and decided to form a fracture assessment tool, and one such fracture assessment tool is called FRAX, where it combines BMD data along with some clinical risk factors to give you a better uh, way to assess and treat these patients. So what you do is you Google FRAX, and you can go and you can put India as the option there, and you fill in the details. You fill in the age, sex, height, weight, if they have had previous fractures, if a parent has had fracture, current smoking, steroids, if patient has rheumatoid arthritis, if they have some secondary causes, alcohol, or femoral neck BMD. The secondary osteoporosis, if you're putting the BMD, the secondary osteoporosis is a dummy input. So it doesn't work if you're putting the BMD values. This can be used also if you don't put the BMD value. At that time, you can put as a yes or no, and then you calculate, and then it gives you a fracture risk assessment. So in terms of the major osteoporotic fracture risk or a hip fracture risk. So what we're looking at is that a hip fracture risk of more than 3.5% or a major osteoporotic fracture risk of more than 10.5% is where we would intervene in these patients. In US, the cutoffs are different. In India, as per the ISBMR, these are the cutoffs. So this patient, as you can see, has a hip fracture risk of 4.9% and major osteoporotic fracture of 13%. So this is a patient where I would say has osteoporosis and we should treat. And I'd give one dose of IV Zoledronate. Okay. Now a 60-year-old female left fracture neck femur admitted in hospital. She's treatment naive. Now, most patients, 80% of patients who get a heart attack are treated with with beta blockers, with the ACE inhibitors, with aspirin. Okay, but only 15% of patients who have an osteoporotic fracture are given treatment post a fracture, which is a very sad situation. So, anyways, now we have all these options. So, what do we treat? We are spoiled for choice. There is a lot of data with regards to zoledronate injection, which can reduce the fractures and mortality after hip fracture. So, this is a good option, and it can be given just prior to discharge of these patients. But there are also other options like denosumab. It significantly reduces the risk of fractures, and it significantly increases the risk of it significantly increases BMD over 3 years. And you can see that this BMD not only at 3 years increases, but also continues to increase at 10 years. So 21% at the spine and over 9% at the hip. And this is in contrast to a bisphosphonate, where at around 4, 5, 6%, it'll start plateauing. And then there will not be a continuous increase like how we see with the denosumab injection. So this patient chose denosumab injections every 6 months. We give 60 milligrams every 6 months. And she completed 3 years. And she was reluctant to take any more treatment. So can we stop this treatment abruptly? So there are studies which have been done where after, for example, after 2 years, you stop the treatment, there will be a dramatic fall in your BMD values at 1 year, and it'll come down to baseline at 1 year. So this dramatic decrease in BMD will predispose somebody to get a increased risk of fractures called rebound fractures. So we must not do that. We cannot stop denosumab if we have taken it. We need to continue it, and if we want to stop it, then we need to give a bisphosphonate, preferably an IV zoledronate, so that whatever BMD has been gained, this dramatic fall doesn't occur, and there's a stabilization of the BMD. Another important point that I want to tell is that patients who have been on denosumab for a long time, they should not be switched from denosumab to teriparatide, because here you can see in the red line at the femoral neck and the hip, there is a decrease in BMD, and this may predispose the patients to an increased risk of fractures at the hip. So the common side effects is hypocalcemia, like the bisphosphonates, but it may occur a little more, and we have to be very careful. We must do a calcium and vitamin D before giving denosumab. The potential risk of rebound fractures, as I discussed with you. So we need to follow up with the IV zoledronate preferably, and osteonecrosis of jaw and atypical femoral fractures, which I will again come to. Coming to the next case, 68-year-old male, low back pain since 1 month, moderate intensity, and we got a X-ray done which showed a vertebral fracture. The vertebral fractures are very common, and it can be silent. Up to 2/3 of vertebral fractures are silent, and patients don't complain, and they are asymptomatic. But this X-ray showed a vertebral fracture. We got a BMT done, and that showed osteoporosis. We got a complete evaluation done of and to especially look for myeloma. So we got a protein electrophoresis done. We showed no M band, and we discussed the option of teriparatide, which is for 2 years. So not for 3 months, 6 months, which is often prescribed by orthopedics. It should be given for 2 years. So this is an anabolic agent. And why this is preferred over other agents? There's enough data compared to bisphosphonate or any other agent that it significantly reduces the risk of new vertebral fractures. Not only that, it also has a significant reduction at non-vertebral fracture sites by 53%. And this is better than any other agent, including denosumab. But the patient did not want to take treatment. He said, I will think about it. Pain is not so bad, it's getting better. And did not want to take treatment. 1.5 years later, he came with a right hip fracture. And so patients who have one fracture significantly increase the risk of another fracture, especially in the initial first few years of the fracture. So there's an imminent risk of fractures with one fracture, and these are the patients that must be on treatment. Now, for this particular patient, he had a spine fracture and a hip fracture, so we give a combination of denosumab with teriparatide. Why I give this combination is that because there is data that shows that, as you can see in the blue line, there's a maximum increase in BMD with a combination of teriparatide and denosumab compared to denosumab alone or teriparatide alone. Coming to the next case, 60-year-old female, diabetic since 6 years, has a T-score of -2, femoral neck of -2.2. So what do we do? Patient is osteopenic. So should we treat? So the ISBMR says that the treatment threshold for patients who are diabetic is -2. The reason being that patients or diabetic patients fracture at a higher BMD compared to the other people, because it's not only BMD but also the microarchitecture which plays an important role in fracture. And diabetics have a poor microarchitecture, so these patients should be treated. What is the other thing that we can do to assess? We can also, in diabetics, we can make rheumatoid arthritis as positive as yes, and then assess the fracture risk assessment. To assess the microarchitecture, some bone density machines, especially at higher centers, have a software in the DEXA machine, which is known as trabecular bone score, to assess the microarchitecture. So a high TBS meaning the microarchitecture is good. A low TBS score means the microarchitecture is poor. And this value you enter into the FRAC scoring, which gives you a overall better fracture assessment to decide whether you need to treat these patients or not. So this is also same for patients who are on steroids. Patients on glucocorticoids fracture at a higher BMD because of poor microarchitecture. So TBS is useful in diabetics as well as patients who are on glucocorticoids. Coming to the next case, a 54-year-old female whose spine BMD shows a 9% decrease in value. So, but if you look at the scan, the labeling is incorrect here. So there cannot be a 9% decrease. Even patients who have accelerated uh, bone loss, it can be up to 2.5%. So if you see a non-physiological decrease in BMD values, we have to think that there is something wrong with the scan, and that is what is here. Coming to the next case, a 64-year-old female on alendronate, the spine increased, the BMD of the spine increased, and the patient was very happy. But should we be happy? If you look closely at the DEXA scan, the one here and the one on the right, you can see the height of the L1 vertebrae is reduced. So actually, this is a vertebral fracture, which is falsely elevating the bone density and adding to the bone density falsely. This patient actually has had a fracture on treatment and will need to be switched to another agent, preferably teriparatide or something else. So we are not very happy. We need to upgrade the therapy. So we must look in the scans in detail and not take the DEXA, just the report at face value. Coming to the next case, 68-year-old male, rheumatoid arthritis on methotrexate, long-term prednisolone. He's on andronate since 8 years. He had come for an opinion because he was feeling that his pains are not getting better, and especially the left lateral thigh pain, which he had since 2 months. We got an X-ray done, which showed a fracture on the lateral part. So this is a atypical fracture, subtrochanteric atypical fracture due to bisphosphonates. And you can see there's a beaking here. So this occurs as a complication of long-term bisphosphonate exposure. It typically occurs, the longer you use it, the higher the risk of this to occur. But it is extremely rare. For example, if you use bisphosphonates to treat 10,000 high-risk patients, so approximately 100 hip fractures and 750 fractures at other sites are prevented. whereas only 3 to 6 atypical fractures could be expected. So the risk benefit, the benefit severely, I mean, far outweighs the risk of these atypical fractures. But this is important to keep in mind. So if the patient's on bisphosphonate complaint of lateral thigh pain, we must do an X-ray. If the X-ray is normal, but still patient has been on long-term bisphosphonates, do additional testing like an MRI to confirm whether this is there. If you confirm that it is there on one side, we must also scan the other side, because there's a likelihood that it will be also there on the side. The treatment for this is fixation along with giving injection teriparatide, uh, so that these fractures heal. Coming to the next case, this is a patient who is on rheumatoid arthritis, who is on alendronate last 3 years, uh, and DMARDs, and the patient has to undergo dental implants and has been referred for clearance. So the dentists are very scared, and what they're scared of is osteonecrosis of jaw. But this is extremely rare. It is in a joking way. So basically, is the risk of fragility fractures, hip fractures are much more common. Getting anaphylaxis is much more common, and death by murder is more common. So extremely rare to get this. Now, who are the typical patients who are at risk of getting this osteonecrosis of jaw? It includes patients who are on treatment for longer than 3 years, oncological patients, diabetic patients, patients on steroids, and patients who have multiple poor fitting dentures, and if they're going to have multiple teeth extractions. So if patients going to have cavities done or just root canals, there is no problem. The issue comes only when they're going to have extractions, and that is when we have to be a little careful. So how do we prevent ONGs? If they are on oral bisphosphonates and if they've been for less than on it for less than 4 years, then we may not delay it. But if they are on it for more than 4 years, or if they are on corticosteroids, then we may stop it for 2 months prior to this procedure and restart once the healing has occurred. But the data for this is very weak, and we don't know how much benefit actually this will have. With regards to denosumab, typically the dental procedure should be done at around 5.5, 6 months when the effect of denosumab is going to go away, so that the healing will occur. And once the healing occurs, you restart the denosumab. So this is the summary slide with regards to the risk of incidence of atypical femoral fracture and osteonecrosis of jaw. Uh, what is important is that the risk of atypical femoral fractures is not been shown with IV zoledronate, which is uh, very surprising. And it this also occurs in non-bisphosphonate users or non-denosumab users. This can occur in those patients as well. So it's important to keep in mind that it's not only the bisphosphonate denosumab causing atypical femoral fractures or osteonecrosis of jaw, it can occur even by itself. So how do we reduce this risk? So that is why we should give something known as a bisphosphonate holiday. So if somebody has a low risk of fractures, by definition, a hip T-score of more than minus 2.5, so whether they become from osteoporotic to osteopenic, uh, and if they have not had any fractures before or during therapy, then one can consider bisphosphonate holiday for 2 to 3 years. If they have a hip fracture, they have a high risk of fractures, then one may consider to continue it up to 10 years for oral bisphosphonates and IV bisphosphonates for up to 6 years. I tell my patients they should do weight bearing. This is some from some magazine where the daughter was diagnosed and the mother was diagnosed osteoporosis. The mother took weight bearing, and the grandmother also took weight bearing. She's 95 years old and did weight bearing. So I'll just summarize osteoporosis. It is not an inevitable part of aging. It is treatable. Osteoporotic fractures can be devastating with not only increased risk of morbidity, mortality, but it also has an increased financial burden. A patient of hip fracture is bedbound. They need somebody there to full time, a ward boy or a nurse to be there to help out. So this and plus osteoporosis treatment. So the financial burden is tremendous. DEXA scan is a gold standard to diagnose. We must look at the DEXA scan in detail. Evaluate for secondary causes. Don't be in a hurry to treat these patients unless they're at high risk of fractures. The indication of fractures, the indications to treat include a patient who had a fracture, a fragility fracture. So that is very simple. Any individual above 50 with a T-score less than minus 2.5, we can consider treatment. In patients who, based on the FRAC score, have a hip fracture risk of 3.5% or major osteoporotic fracture risk of 10.5%, we should treat. In diabetics, as I told you, if T-score of minus 2 or less, we should treat. Now, if it is early postmenopausal, if they're premature menopausal without a fracture, we must consider hormone therapy. If they are in their 50s, 60s, we can consider bisphosphonates and also denosumab. But if they have very low BMDs, if they have a history of multiple fractures, then we must always use an anabolic agent first. If patients have multiple fractures, they having fractures of spine and hip, then we can consider combination therapy with denosumab and teriparatide. Now, regarding sequential therapy, anabolic agent should always be followed by antiresorptives is preferred because the maximum BMD rise occurs this way. So always anabolic followed by antiresorptive preferably. Don't switch from denosumab to teriparatide because there will be a decrease at the hip. We must use bisphosphonates, preferably IV zoledronate after denosumab to prevent the risk of rebound fractures. And teriparatide should always be followed up with either denosumab or bisphosphonate. Otherwise, we will again lose the BMD, though not very quickly like how we lose with denosumab, but over a period of time, the BMD gain will be lost. I would like to end my talk here. Thank you for the patient hearing.
Excellent talk, Dr. Punit. You have covered up on all the practical issues which we face in day-to-day practice. It is very important what Dr. Punit said, checking the calcium phosphorus level to rule out secondary causes of osteoporosis. If you see many reports, they will only report the serum calcium. Nobody many times does not include also the phosphorus levels in the reports, and even if it is there, they don't look at it. So we have had patients who have had low phosphorus since many years and being treated, nobody has even seen at the phosphorus levels. So very good take-home messages. If anybody has any doubts, you can please ask. I think Dr. Punit has covered everything in good detail.
Excuse me, I'm sorry. Just the last part where you were saying that denosumab should be followed by IV zoledronate and it should this thing that this should not be followed by this and like denosumab should not be followed by teriparatide or something. I'm not just clear about that part, if you don't mind.
Yeah, sure. So denosumab, if you stop abruptly, there will be after 6 months of the last dose, at 7th month, there will be they will start a decline in the BMD and a rapid decrease in BMD values. Now, to prevent this loss, we need to give something that this loss is prevented. So the way forward is giving IV zoledronate. Now, patients who have been on denosumab for a couple of years and you follow it with teriparatide, it has been shown that there will be a decrease at the hip BMD, and this decrease in hip BMD will increase the risk of hip fractures. So denosumab cannot be followed up with teriparatide because that has an adverse effect on the BMD values.
Yeah, Dr. Punita had a...
Yes.
Your question is answered, Doctor?
Yes, thank you.
Yeah. Okay. And Dr. Punit, about the combination of denosumab and teriparatide. So this is the recent literature now using a combination?
Yes, so this is based on the data study and the data HD study where it has been shown that combination therapy works very well. So you can combine denosumab and teriparatide in patients who are very high risk, imminent risk of fractures, where you want that the BMD should rise very rapidly so that the fracture risk reduction occurs quite fast.
Okay. Thank you. Any other questions?
So sometimes sometimes people are put on alendronate, oral alendronate when they see, like I recently saw one of my aunt, she was put on alendronate because she had osteopenia actually on her DEXA scan report, but she was put on alendronate. So if you could suggest on that, like advice on that.
Correct. So as I mentioned in my talk that uh, one thing is clear, we definitely treat osteoporotic patients, but osteopenic patients we may also treat if the fracture risk is on the higher side. Now, how do we assess whether the fracture risk is on the higher side? We can use tools like FRAX, where we put in the data and it gives us a score. So if a FRAX score of more than 10.5% major osteoporotic fracture risk, or the hip fracture risk more than 3.5%, if it is there, then we can put these patients on treatment, and that can be alendronate or whatever it is. Yes, I hope I've answered the question.
Any more questions? Okay. So I think we can end the session today. Thank you, Dr. Punit, for this informative session. And thank you everyone.